Okay, I guess we're here for the Q&A session. Sheila, I think if we can perhaps go through some of the questions we have in the comments. My name is Dr. Allison Mayu. I'm an internist in Marshfield, Wisconsin, and I served as a caregiver for my brother. And so I'm happy to help the MSA Coalition, who was a great resource for us, and conferences like this just helped us tremendously as we journeyed through that disease with my brother. Sheila, if you want to give yourself a brief introduction.
Sure. I'm Sheila Storch. I am the neuromuscular social worker at UT Southwestern in Dallas, covering the MDA, ALS, and MSA clinics, as well as the memory clinic. So I have been here for about 2.5 months. So glad to be on board. Help any way I can in this conference.
Okay, I think our first questions for the medical portion probably start at about 12:30 Eastern, if I'm not mistaken. The first question is, and please feel free to jump in for the specialists that gave the presentations earlier. I was seeing patients with the first presentations. What are the best ways to prevent a bladder infection?
So I guess that one's for me, Gary Lamack from UT Southwestern in Dallas. And yeah, tricky one because there's no one size fits all for bladder infections. So it's a little different if you're, say, a postmenopausal woman that's having recurrent bladder infections, in which case we know water intake, 6 to 8 glasses of water a day can be very helpful. If you have vaginal atrophy, which is something that can be figured out on exam pretty quickly, vaginal estrogen can be very, very helpful. If emptying your bladder is a problem, which many of times it may be in folks who have neurologic conditions, including multiple systems atrophy, trying to empty your bladder, double void if necessary, going back and emptying your bladder further. There are some over-the-counter products, not any of which are particularly well proven, but cranberry supplements have some legitimacy. Something called D-mannose has some legitimacy. That may help you prevent infections too. If all else fails, then a very low-dose daily antibiotic in the right patient can be very helpful and will not lead to resistant infections. So you need to see your doctor about if that will help or not help. If it's really impaired bladder emptying, and that's the big problem for men or women, and that's not better by just double voiding, then occasionally, as I mentioned, getting your bladder more empty can be helpful. Sometimes that can be achieved surgically. Most of the time, in folks with underlying neurologic conditions like multiple system atrophy, that may require something like intermittent catheterization. So a lot of things to think through, not all one size fits all, but those are sort of the major tenets of trying to prevent infections.
Okay, Sheila?
All right, I'm looking here. Let's see. So I think this might be more towards Dr. Chaffis. We've got somebody wondering if this has worked. Oh, wait, question. I am curious, do most groups request that a support friend who comes into the home take a COVID test each time before they enter the house? Oh, that's, I'm not sure who that's for. You know, I'm not sure about a COVID test every single time, but trying to see. Another one is that we have another one that is asking her husband's caregiver. I am my husband's caregiver, and it's hard to ask others for help. I have learned that people are very willing to help. They just need to know exactly what needs to be done. I never ask people to do things they don't want to do. Even something that is as simple as picking up a prescription is a huge help. So let me see if there's anything else.
I will comment on the topic of asking for help. I noticed that on my recording, I tried to say, I don't know if it's going to come across here, did not come through. I think it was silent on my recording, but I meant the word ah. So I vocalize better. That's what I meant. So I would stress the importance and the value of assertively asking for help. No one can do this alone, and everyone else should be glad because there, but for the grace of God, go they. Right. So we need to be a community and a family and help each other.
Well, and Dr. Schliff, in that respect, there's also one other comment that could loop into that while you're talking about that. We had one caregiver say, my husband is mean to me. I would not be able to care for him if I didn't take antidepressants. Can you speak to that?
That's complicated. I wonder if he was mean before, or if this is a personality change, and or if he's simply not quite Superman enough to be delightful, even though he's had serious losses and daily life is really hard. First and foremost, I think the wife, the questioner, should find a counselor to discuss her specific case in detail, because she deserves support and help with problem solving.
Okay, I think this question would likely go to Dr. Freeman about the orthostatic hypotension. There was a mention during your presentation about slightly higher blood pressure being less dangerous in the patient with orthostatic hypotension. But would it be alarming to see in a patient who normally has very low blood pressure, or is it normal for blood pressure to become more erratic as the disease progresses?
Yep. So that's a good question. Blood pressure definitely becomes more erratic as the disease progresses. I think the point I wanted to make during the presentation was, don't be overly concerned about high blood pressures. I think anybody who watches, TV, reads published service announcements, reads the newspaper, is fully aware of the long-term dangers of high blood pressure. But the important word in that sentence is the hyphenated long-term damage. And so I think it's really important not to be too concerned about transient increases in blood pressure. And by transient, I mean temporary, and I mean lasting, not just for minutes, but even for hours. And to be mindful of the fact that you can lower the blood pressure. One can lower the blood pressure just by standing up, or by having a glass of wine, or by having a meal that is high in carbohydrates. So the question, high blood pressure, do I need to worry about it? Not too much unless it is sustained. And by sustained, I mean days and days. One. Two, does this occur as the disease progresses? That means, do the fluctuations occur? Yes, they do. The controlling mechanism for blood pressure is what is lost. And don't overreact. Be zen about it, and being zen will lower the blood pressure almost immediately. So blood pressure is very responsive to how you're feeling and how you react. So the more anxious you are, the more likely the blood pressure is going to increase.
Okay, I see another one for Dr. Freeman. Is drinking tap water rapidly better than drinking Gatorade for raising blood pressure?
Two different things. Generally, I don't recommend Gatorade, period. I think what you need is fluid, 3 liters of fluid a day, and salt, 4 to 6 grams of salt a day. The rest of the stuff that you pay to whatever company makes Gatorade is unnecessary. Most of the other electrolytes that may be added are not necessary. Fluid and salt is all that you need. It's, the colors are not as pretty. It doesn't look as good on the shelf, but it does the trick. So that's every day. 4 to 6 grams of salt a day, 3 liters of fluid a day, no discussion. Then the and I say no discussion, but I do want to emphasize, I know that there was a talk by the bladder guy whose name I forget, and who, spoke about fluid and intake. And I don't want to underemphasize what it means in ingesting 3 liters of fluid a day. It means knowing where the bathroom is. It means having to wake up at night. It means having to wake up at night when your blood pressure may be low. This is one of the challenges of the disease. You do something to treat blood pressure, you affect the bladder. You do something to treat the bladder, you affect the bowels. It is a very, very narrow and precarious path that you are walking on. And I don't want to, for a moment, pretend that none of us, we understand the narrowness of that path. But looking at the blood pressure in and of itself, 3 liters, 4 to 6 grams. Then there's another story, and that's the rapid ingesting of 500 cc's, and that's just tap water. Must be tap water, no salt, no Gatorade, no Diet Coke, just tap water. And it's a magical reflex which instantaneously raises the blood pressure 20 millimeters of mercury, which is the difference between fainting and not fainting. So that's the emergency intervention that you have in your back pocket, making use of this magical, and it really is magical, that the blood pressure goes up, and it can go up for up to an hour, but it goes up very quickly, and it goes up 20, sometimes even 30 millimeters of mercury. You've got to plug it down, as I said, like the college students do. You've got to down it quickly within, ideally less than a minute. Again, I don't want to trivialize the challenge. That's a challenge, but that's how to engage that reflex. So if you're up in the grocery store, middle of buying your groceries, and suddenly you feel lightheaded, 500 cc's of tap water.
Okay, we have another question from the urology standpoint. Patient states that her husband has a lot of urinary retention and urgency, and he's had periodic urodynamic studies. Eventually, he was retaining too much urine and was instructed to self-cath, and he's been doing that for over a year. Is there any reason to repeat another urodynamic study? He knows when his bladder is full, but is unable to empty it on his own.
So in general, the answer is no to that question, unless there's been some clinical change. So, and what I mean by that, if they have new onset leakage, if they begin to void someone on their own, which would be unusual, if they start having a lot more infections, they have to have difficulty catheterizing, those may be signs you want to repeat the studies. If none of those things are happening and it's stable, he's on a stable intermittent catheterization regimen, he's not leaking, he's not having infections, can pass the catheters pretty regularly, most would advocate that you really don't have to retest, unless something new is going on. So it sounds like he's been adequately assessed and is relatively stable right now.
All right, there's another question. My brother has MSA. Can he still take Q10 for protecting his heart as he used to? Does anybody know the question to that?
I missed the question. I wonder if you could repeat it. Can he still do what for his heart?
My brother has MSA. Can he still take Q10 for protecting his heart as he used to?
Are you talking coenzyme Q10? Is that what you're talking about?
They said Q, yeah,
Okay. I'm happy to answer it, but maybe Mitch, who's been quiet, you can either continue to enjoy the peaceful atmosphere it looks like is in his background, or we can try and answer that question.
I think he's on mute, is what I'm seeing.
Oh, no wonder he's so peaceful.
There we go. Okay. Do you want me to repeat that question? Or?
Do you want to answer it, Mitch, or do you want me to? I don't have a good answer.
I would punt it back to you. I don't have as much experience in that.
There seems no reason why not. It's a pretty benign intervention. I don't see a reason why not. As to its efficacy, it's still obviously open to debate.
I think there were a couple of questions that were related to the GI tract. One being fecal urgency, because they had constipation had been addressed, and I'm hoping if we could, the swallowing difficulties. Will gulping hurt? Do we have anything from a GI perspective?
Gary, is that close enough to your area of expertise?
I can't speak to the gulping. I can speak to the fecal issues. So, in most of these situations, the neurogenic bowel follows kind of the neurogenic bladder in the sense that you have relative issues with evacuation. And so sometimes the fecal urgency has more to a problem with evacuation than it does to other issues. Occasionally you'll have some sphincteric incontinence too, fecally. So I guess if I were in that situation and the normal things haven't worked, I probably would see a colorectal folk or a person or a GI person. There are occasionally, rarely, some other interventions besides medical interventions that can be helpful. So I can't say that you would never potentially have an option there. So I guess I would get evaluated, but it's more often a constipation that sometimes results in kind of this overflow situation.
Yeah, I would think, if there's any aspiration risk, then that may not be a great idea if you're aspirating. That's probably the bigger concern, but otherwise I wouldn't see any major problem.
I see another one that says, it was said that REM sleep and acting out in sleep is later in MSA, but can it come earlier in MSA diagnosis?
Yes, it can. In some patients who present more with the autonomic failure, it's more likely that the RBD, the REM sleep behavior disorder, will occur after that. So that's what my comment was addressing. You certainly can develop REM behavior disorder first, but it's unusual to develop that, say, years or decades before the other symptoms of MSA. If that's the case, it's more likely that a patient's going to develop, say, Parkinson's disease, because usually the sleep, the dream enactment comes out, in the middle or later in the disease, and it's more dramatic than in these other synuclein disorders where it's much, much earlier.
I guess we're being told that we've got to wrap it up. Gosh, there's so many other nice questions that would be helpful, but a lot with regards to the genitourinary issues and also from the neurology perspective with medications, tremors, etc. I don't know if they're going to tell us to actually wrap up, or could we just have maybe one more question? Let's see.
It looks like there is one question. What blood pressure is considered too low?
Okay. These questions are, really get to the heart of the matter. It's another very good question. So, too low, and this is going to sound a little flip, but I'm going to elaborate it. So don't cut me off mid-sentence, because you'll be left with the flip part. So too low is that results in fainting. And too low is that results in inadequate blood flow to the brain. And obviously, as if you listen to my talk, that's the critical aspect of blood pressure control, making sure the brain gets enough blood flow. So we work in a world of numbers, so you want a number. And so generally, we think of most patients being symptomatic round about 90, but it's only most patients. And we think of there being adequate cerebral blood flow round about 90, a systolic blood pressure of round about 90. But there are many patients, can be up to a third of patients, that will be asymptomatic when their blood pressure reaches 90 or even lower. And you may remember part of the talk, I showed those figures. So you need to know, you as the patient or you as the caretaker need to know when you get symptoms and how that relates to blood pressure and work around that. But I cannot emphasize enough, the worst part of low blood pressure are the potential consequences falling, fainting, breaking a bone, fracturing your skull, having a brain injury, and the last thing you want to do is that. So worry more about the low blood pressure than you do about the high blood pressure.
All right, it looks like they're asking us to wrap up at this point. So any other final comments? I want to thank you all for being here with us.
Pleasure.
Thank you all so much.
Thank you.
Thanks for having us.